Okay.
I'd like to thank Caroline. She is a professor at Tufts University to share with us her knowledge. She's going to speak about OCT, and it's up to you, Caroline. Thank you again.
Okay. Sure. Well, let me just screen share, and I want to tell everyone thanks for having me. It looks very sunny there. It's not as sunny here. It's still about 15. It's like 15. It's cold. Okay, let me just do this. Screen share. Okay. Everyone, can you see my screen?
Yeah, it's perfect.
Perfect. Great. Let me get to the beginning. All right. So thank you for this opportunity. I'm going to talk about imaging and some advances in imaging. I'm going to give you a whole kind of smorgasbord about imaging and what I think is interesting, and review some of our research and clinical papers. So I was told I have a lot of time, so I put a lot of stuff in here. So I'm in Boston at Tufts Medical Center, and we have a big, as I was saying to Rodrigo, we have a big Brazilian connection, which we're so grateful for, because we have so many bright people coming and doing research fellowships with us from Brazil. So I think that we have a lot of options when it comes to retinal imaging, and we're so fortunate because the eye is so uniquely set up for imaging, the retina particularly. So some of the utility of our imaging is used clinically, and some is for, oops, hold on a sec. Sorry, there we go. So we have imaging that can show us structural information. We have other imaging that can show us functional, and some is just for research. And here's a whole list of most of the different types of imaging. There might be some research-based types that I don't have in this list, but we have fundus photography, and we have lots of options with that. Color fundus, monochromatic, or autofluorescence. We have dye-based angiography. We have ultra-wide field fundus imaging, which is not just fundus photographs, but also fluorescein and OCT and OCTA. We have separately OCT and OCT angiography. We have ERG, Doppler, ultrasound, and more research-oriented hyperspectral imaging, adaptive optics, and FLIO. So we have so many options to help us in our patients. So some imaging is used for clinical, and some is used for research. And we can use our imaging for documentation, diagnosis, classification, progression, and to stratify risk. I think one thing that has really been useful, at least in the last year, has been to use imaging for telemedicine, even kind of cutting out the clinical exam at time and using our imaging to either direct treatment of our patients or to make the visits even faster. Imaging has also proven, unique in having us assess therapeutic efficacy. And one of the big things was that OCT and anti-VEGF treatments really took off at the same time, and OCT helped us demonstrate the efficacy of anti-VEGF therapy. We can also use imaging for screening, and then for research to understand pathogenesis of disease, animal models of disease, and to look at new phase 1 therapies. So with all these imaging advances, we have new terminology that comes up. And one of these is multimodal imaging. And I was involved in an editorial actually with Eduardo Noves, who's from Brazil. And we define this as the use of more than one technological system to acquire images that complement one another for diagnosis, prognostication, management, and disease monitoring. So we can do multimodal imaging to better understand what the disease is. Also, we have major advances in technology that are continual, looking at automated image interpretation, software, understanding the ischemic index of the retina, telemedicine, using mobile apps. And one of the big breakthroughs in technology was registration of the clinical and OCT images. So being able to register images between exams, always look at the same point, and register different imaging modalities to be looking at the same region. So I'm going to talk a little bit about wide field imaging and how that has evolved. And here you can see one of the earliest fundus images. This was in 1905 by Dimmer. And as things go on, we can see that we've gone bigger and wider and gotten more detail in our fundus imaging using 7 standard fields of 30-degree images, and then using contact lens and a wide field imaging. And wide field imaging is not just for color fundus photographs, it's also for fluorescein angiography and OCT angiography. And you can see on the left, the ion scanner, which mosaics 4 wide images together, then the Optos. And then to the next image, we see the Zeiss images from the Zeiss Claris, which montages multiple images, and the Zeiss Plex Elite, which is a wide field swept source OCTA. And then on the right, we can see a full eye OCT with from the Heidelberg with an Optos color fundus photo. So we're getting wider and able to see more of the retina with our imaging. So wide field imaging has been a big advance for us, and we can look at color fundus photos, autofluorescence, wide field fluorescein and ICG angiography, and OCT angiography. And you can see below is an Optos color fundus image, and to the right is a multi-image mosaic swept source OCTA. And you can see there's areas of neovascularization with more peripheral areas of non-perfusion. Here's another case of wide field imaging that helped make the diagnosis in this patient. And I find that wide field imaging, we have this Zeiss Claris OCT, the Zeiss Claris fundus image, fundus camera. And patients often, especially pediatric patients, because I see a lot of pediatric retina issues, they're more amenable to have the fundus image than the clinical examination. So it might be easier to get the image in some cases before examining the patient. And this is a patient with proliferative diabetic retinopathy who had these 2 infratemporal areas of neovascularization with fibrosis. And this was really seen on wide field imaging, but would have been missed with a standard color fundus photo. So what is a standard fundus photo? Well, you can see that on the left here. This is showing the 30-degree standard field. And on the right shows a mosaic of multiple standard field fundus photos. What are the benefits? Well, the 30-degree standard field, it's easy to do. It's simple for a photographer or someone who doesn't know a lot about photography to take. It's readily available. This 7 field is often used in clinical trials, but there might be features that are missed from just looking at even the 7 standard fields.
Ultra-wide field imaging provides a 200-degree wide field image of the retina.
So if you look at the standard 7 field put onto a wide field or an ultra wide field image, as in this, you see how much of the retina is missing in just looking at the 7 standard fields. So with all this new technology, there really is a need for new language to describe what we're seeing. And this was a really great paper that came out about classification and guidelines for wide field imaging. And the reason it's important is that we're all looking at the same thing and describing it in the same way. So what this paper does is it incorporates retinal anatomic landmarks into the definition of wide field imaging. Excuse me. In that way, these anatomical landmarks are consistent with our clinical examination, and it gives consistency across various imaging modalities. It also takes into account whether montage was done to make the image or whether it was done with a single photograph. And it brings a new term, pan-retinal, which is a 360-degree aura-to-aura view of the retina. So based on this recommendation, the posterior pole is the retina within the arcades and just slightly beyond. And that's really what we use clinically in our definitions. Mid-periphery is the region of the retina up to the edge of the vortex vein ampulla. Far periphery is the region of the retina that's anterior to the vortex vein ampulla. So for this definition, wide field describes a single capture image that's centered on the fovea and captures the retina in all four quadrants, posterior to and including the vortex vein ampulla, shown there. And then ultra-wide field is a single capture view of the retina into the far periphery in all four quadrants. And pan-retinal is a single capture 360-degree aura-to-aura view of the retina. So in this classification, this is showing the OCT B scan, and you can see that in the bottom of the image. So the B scan is the cross-sectional OCT. It's also called the structural OCT. It's referred to differently in the literature. And the recommendation from this paper is to describe the size of the B scan, the location, the type of scan that's done, whether it's a montage or not, and the symmetry. So we can see in this picture, in A, there's a lesion inferior in the retina, and in B, the OCT scan is done through the lesion. So it's not done through the fovea. So it's a targeted OCT through the lesion. C shows what the OCT B scan shows. It's a 12 millimeter length scan in the far periphery inferior OCT B scan. So it's important to describe this to understand where the lesion is. So for OCT B scans, the description should include the size of the B scan, the location, the scan type, whether it's a montage, and whether there's symmetry. So here we see there's a 49 millimeter asymmetric pan-retinal OCT B scan montage. You can see there's this amazing OCT completely through the eye. What about en face OCTA? So en face is a way that we often look at OCT angiography. And when we do OCT angiography, we can have a structural OCT, which is on the left, and typically that is co-registered. That's shown with the OCTA, which is on the right, which is an en face. It's directly looking at that view. And there's variable sizes to the OCTA. It can be 3 to 3, up to 15 to 15, depending on which device is being used. So this is showing on the left how we compare in the same eye. On the left is a wide field fluorescein, and on the right is a wide field OCT angiography that is made by stitching multiple 3x3 OCTAs. So the recommendations for en face OCTA is that wide field describes images that capture the retina in all four quadrants up to and including the posterior edge of the vortex veins, and ultra wide field would be an OCTA image that goes beyond the anterior edge of the vortex vein. So on the bottom left, it's a 12 millimeter posterior pole OCT B scan showing the flow overlay, which is in red. And on the right is a 12 by 12 posterior pole OCTA. In this picture, we can see that there's a 24 by 24 asymmetric wide field OCTA montage that was made from multiple images. So all of these descriptions are really important in order to compare devices and know exactly what we're looking at. Here's another picture that I took. This is showing a wide field swept source OCTA, and you can see this patient has neovascularization in the right eye coming off the disc with peripheral ischemia, and in the left eye, all of this neovascularization elsewhere with peripheral ischemia. So to summarize wide field, it's important to understand and be aware of the terminology, and this is one recommended way of classifying, where the posterior pole is about a 50-degree view looking at the retina just beyond the disc and arcades. The mid-periphery, which is consistent with wide field, shows 60 to 120 degrees, including the retina up to the posterior edge of the vortex vein ampulla. And the far periphery is 110 to 220 degrees, consistent with ultra wide, going from the anterior edge of the vortex veins and beyond. And this consistent nomenclature will help us understand and categorize what we're seeing. So wide field photos have been indispensable for looking at certain disorders such as diabetic retinopathy, retinal vein occlusion, choroidal tumors, uveitis and vasculitis, retinal tears and detachments, and ROP. And you can see some of the examples here. Wide field fluorescein has been amazing to look at diabetic retinopathy, retinal vein occlusions, and vasculitis. And I'm going to show you a case. Here's a patient with diabetic retinopathy, and we can see that the wide field helps us look at the wide field color fundus photograph. We can see that there's PRP and that there's NVE along the supratemporal arcade, and the wide field fluorescein gives us so much information. It helps us see how much ischemia there is, helps us look at the NVE, and helps evaluate and prognosticate how this patient will do. Wide field angiography has also been beneficial in patients with sickle cell retinopathy. And this was a paper looking at detection and monitoring of sickle cell retinopathy. And it showed that in all but one eye, ultra wide field fundus photography and fluorescein could detect peripheral vascular changes that were not seen on the 7 standard field imaging. So we can see here the peripheral leakage on the bottom right from the fluorescein angiogram and the peripheral laser with some skipped areas with ischemia, and this is consistent with the color fundus photograph. So this can play a big role in evaluating, screening, and treating these patients. Wide field fundus photography has also been useful to look at choroidal tumors and retinal tumors. Here's a patient with von Hippel disease, and we can see that there are these very subtle peripheral lesions that may be missed with standard fluorescein or standard color fundus photography. So it's useful to have a consistent nomenclature for wide field imaging. It gives us more information about the retina, and we can use this nomenclature across multiple imaging modalities. So I'm going to go on to OCT now. And OCT was originally developed as a research tool, actually as a collaboration between MIT and Tufts, which is where I did my fellowship in 1995. And so I've been very fortunate to be able to play a role in development and a lot of research with OCT. And OCT's gone from something that was, you know, I can tell you in the beginning of my fellowship, people would be like, oh, this is never going to work. What is the use of this technology? We can do everything from exam. So now it's an indispensable part of what we do. And it really, in some cases, takes precedent over the clinical examination. And the one thing about OCT is that it's still evolving. We have not maxed out. There's still improvements in hardware and software that I'm sure will come. And I'm going to show you some of those. So it was originally, the reason it was developed was to be an optical biopsy, to really give us the detail that you would see with pathology, but in real time without having to cut into tissue. So it was originally the idea was to have it be a way so we could see the photoreceptors and tell exactly what was going on in the retina. And this is just a little bit about the history of OCT and how it's developed. The seminal paper was in 1991 in Science with some of these people who are, you know, they're mostly all still very active researchers, including David Wang, James Fujimoto, and Carmen Puliafito. The first prototype was used in 1993 at New England Eye Center in Boston. So I was there in 1995, and we got to use the prototype on patients in the clinic. Then the technology was transferred to Zeiss, and OCT1 started production. And there were different iterations of OCT as technology, hardware, and software got better. It was OCT1, then OCT2, then OCT3 in 2002. But it was really when spectral domain OCT, when this technology became discovered in 2004, and then the clinical systems became available in 2006, analogous with when anti-VEGFs were gearing up, that OCT really exploded. Then multiple companies began making OCTs. There were 9 systems available in 2012, and there's more now. And OCT took off exponentially at that time with spectral domain OCT. And then in 2014, 2015, the first OCT angiography systems became available. So this shows the images that were obtained in this seminal paper in Science. You can see at this time, this was really remarkable that we could get images like this at all. And this shows the evolution of OCT. On the top, we see OCT 1 and 2, the sort of images we saw, then OCT 3, and at the bottom, spectral domain OCT with about 5 microns resolution. And you can understand why this was something that made people say, okay, now I want to have one of these in my office. This is referring to the international OCT nomenclature, and there have been other nomenclatures put out, but this is pretty standard that, you know, I often use to look at. This is using a very high resolution OCT and describing the anatomy that we see in the retina. And you can go through all the different layers here, from the internal limiting membrane to the external limiting membrane to Henle's layer in there. And I always kind of look at this because when I look at abnormal OCT, I like to go through the anatomy layer by layer to make sure everything looks like it should. So OCT has amazing clinical utility. We use it for macular diseases, for diagnose, to follow the course, to look at our treatments, to understand disease pathogenesis. We use it to look at the separation of the individual retinal layers, to look at the vitreomacular interface, to understand choroidal disorders, to look at the optic nerve and the nerve fiber layer, and also to look at the cornea and the anterior segment in the front of the eye. And it's really been key in looking at, just to name a few of the disorders that we look at, all of these, especially AMD, diabetic retinopathy, central serous, and DME, and all of these other issues. OCT has been critical in our understanding and diagnosis. So, you know, it's always important to consider what type of scan and what sort of information do you look at when you get an OCT? Because I like to use the OCT to maximize what I'm looking at. I don't want to do an OCT and miss something. I like to get my scans and make sure I have all the information I need to see the pathology in the majority of people. So I would typically get a retinal thickness map. And you can see increased thickening, for example, in this case, that can correspond with leakage. It will often correspond with fluorescein leakage. And the thickening may also correspond with the visual acuity. So in my patients, I like to get a thickness map so I can see what the different colors show. I like to look, it helps me to know if they're what they should be, if it's too thick or too thin. I also like to get multiple OCT line scans, which is called the OCT-B scan. It's also referred to as the structural OCT, because the maps alone do not provide the sort of detail and do not show us the vitreomacular interactions. Also don't show the choroidal thickness. So I like to do multiple line scans, and I always look in the grayscale, which I think is really important, and I'm going to talk a little bit about that later. I typically like to do the longest scan possible. I do 9 or 12 millimeter scans in every patient that I see, and I always like to do EDI, which is called enhanced depth imaging, which shows better definition of the choroid. So just to show a few examples where OCT has shown great utility, it has been very helpful in evaluating macular edema to detect subtle macular edema or whether there's vitreous pathology related to the macular edema. It's been used to classify diabetic macular edema, and it has been really critical for us in playing a role in macular pharmacotherapy. So here we see on the top the thickness map, where red is showing the increased thickness of the macula on the cube, and in the view below we see the details of the intraretinal cystic changes. Here's another case where this clinically might look like DME, and we see on the OCT-B scan, the structural OCT, that there's actually pre-retinal membrane and vitreomacular traction, in addition to intraretinal cystic changes and some subretinal changes. Here's another place where OCT has just really improved our understanding of vitreomacular traction and understanding the course of vitreomacular traction. I don't think we had this understanding to this degree before, because it was not always imaged with fluorescein angiography, and it was difficult to image clinically, even with a contact lens on the eye. So this shows on the top a patient with vitreomacular traction, and this spontaneously resolved and the patient's symptoms improved, and we can see that as it released, the foveal contour was back to normal. So OCT has been critical for us to understand what happens with vitreomacular traction. It can go on to spontaneous PVD, it can remain stable, or it can progress to more severe anatomic distortion. It can progress to a full thickness macular hole. It can progress to a lamellar macular hole or to an epiretinal membrane. And it really helped us understand, there was a theory before where Gass's theory of macular hole was that it's tangential traction, but now I think we know it's more anterior posterior traction from the vitreous. And this is a patient who had this small focal area of vitreomacular traction. It's a tiny little distortion of the inner retina, and this patient was symptomatic, and clinically the patient looked normal. There was very little to see, and then 3 weeks later the symptoms resolved and the patient developed vitreous separation over the fovea. Also was very useful to classify macular holes as small, medium, or large, which plays a role in understanding surgical prognosis and looking at patients postoperatively. Here's another thing. It's been useful to help us characterize lamellar macular holes and pseudo holes from full thickness macular holes. As well, I like to use my OCT surgically. I look at the epiretinal membrane. It actually helps me decide where I'm going to start to peel my membrane and get an idea whether the membrane is very tight or whether there's multiple spaces between the membrane and the inner retina. And it helps us look at these patients after surgery and to show them that the pathology improved. Another place where OCT has been critical is looking at things like hydrochloroquine toxicity and helping us understand the early changes that go along with this and when to tell patients to discontinue this medication. So we talked a little bit about what your scan protocol is, and I work in a practice with 6 other retina physicians, and we all have a different scan protocol. One of the reasons why I think that some things had previously not been seen on OCT is because a lot of people were using the colored images, the false color images that show this color scale to look at OCT B scans. So it's important to define what your imaging protocol is. I told you what mine is. I like to do a long scan with EDI and multiple cuts and a cube. But if you look at a picture like this, you might miss the pathology. And I think that this has led to certain diseases that were there all along, but maybe we weren't seeing them because of looking at the colored scale. And also the technology has gotten better. So here, this is the same patient. This patient has a retina problem, and I'm going to show you what it is. If you look at this patient now, we can see that this patient has this outer retinal hyperreflectivity deep in the retina, okay? So this patient, and this is the same patient as this patient. So this is showing a more recently described entity, acute macular neuroretinopathy, where patients get these dark red-brown, wedge-shaped, non-elevated macular lesions. And this occasionally with a flame-shaped hemorrhage. It's pretty uncommon entity, and it has been related to multiple predisposing factors, viral, hyperepinephrine, but more recently characterized. And, I always wonder, wasn't this there all along? Were we just missing this because we didn't have these higher resolution images, or were we looking at the color scale? Here's another patient who shows an entity that was only more recently characterized, but it's probably been there all along. This is a patient with a retinal vein, an impending retinal vein occlusion with PAM, paracentral acute middle maculopathy. And if we look at the OCT, we see this hyperreflectivity, but it's more anterior to what we saw in AMN. It's in the middle retina, and there are these focal regions of hyperreflectivity. And this is thought to be related to middle retinal ischemia. So it's just interesting that these entities have always been there, but only recently characterized within the last decade. So OCT, can we make this even better? And the answer is yes. And there's certain things that we can do to improve tomorrow's OCT devices. We can have better light sources. We can have a broader bandwidth light source with better resolution. We can have light sources to image the entire globe, and we can use longer wavelengths to penetrate into the optic nerve and choroid better. We can also have faster speeds, and we can improve our software, have automatic reading, and machine learning or AI. So we still have a lot of improvements that we can do to make this better for our patients. Here's an example of showing better software to quantify geographic atrophy and also to quantify pigment epithelial detachments and subretinal fluid. So here's a 74-year-old male at baseline and you can see that at 6 months of follow-up, the sub-RPE slab shows a larger area of atrophy. There's also several companies that offer this type of software now. And you can see here software to quantify the pigment epithelial detachment. So this is just showing a patient who was on monthly ranibizumab and followed using the retinal thickness map, the RPE map, and the PED volume. And over time, the PED volume is reduced. The RPE map shows the change in the elevation of the RPE, and the thickness map shows the PED resolving. So we can use these quantitative values to follow our patients better. We can also get better axial resolution with higher pixel densities and image averaging. And with more technology and faster machines, we'll have better access to do this for our images. Also, longer wavelength will give better penetration into the choroid to characterize choroidal disorders, which has really been done in the last decade, understanding what the pachychoroid diseases are and what happens to the choroidal vessels in these entities. Faster speeds, we have this now with spectral domain OCT going up to 90,000 A scans per second, and swept source OCT can go up to 400,000 A scans per second. And then there's also an experimental short cavity swept source OCT. So all of these speeds and technology, faster speeds will give us higher pixel density oversampling, more image averaging in less time. We might be able to scan so quickly to eliminate motion artifact without having to use mechanical tracking. And we can even get better fundus images. You can see the image here in the middle is an OCT fundus image, and this may help to eliminate the need for fundus photography. And we can also get three-dimensional reconstruction of images. So this in the right here shows an OCT fundus image obtained, and we can see that's very high quality. Better software to eliminate motion artifacts. We can see this is a 14 millimeter B scan OCT with 90 B scans and averaging. Future OCTs may also help us to image the cone mosaic, use adaptive optics with swept source OCT, and maybe even measure blood flow or do functional OCT. So our ceiling has not been reached with OCT. We're going to have faster speeds, better resolution, better software, expand the utility of OCT, and this will, I hope, help us better understand disease and new therapies. So I'm going to wrap it up by just talking a little bit about OCT. Rodrigo said I had a lot of time. Am I okay for time, Rodrigo?
Yes, sure.
Okay. Let me know when you want me to wrap it up, but I have just a little bit about OCTA because I think this has really helped me in my clinical practice. OCTA is a way to visualize flow in the microvessels by detecting motion contrast of moving blood vessels, moving blood cells. So I always have to remind myself, this is looking at flow. It doesn't mean that there still might be vessels imaged in an area, but it's looking at the flow in that region. And we can get these three-dimensional images of flow in the retina, choriocapillaris, and choroidal vasculature. There's no dye injection, so it's faster than fluorescein or ICG. We can also repeat it at every visit, and the images are very sharp. They're not obscured by dye leakage. However, it's a little slower than your structural OCT B scan. It requires very high-speed instruments. Regions of very slow flow or flow impairment may not be detected. We can't detect vascular permeability or leakage, and it depends on motion, so there can be multiple artifacts, and it's important to understand the artifacts and the terminology to interpret the images. So it works by motion contrast. Multiple B scans are obtained at the same site, and decorrelation, what decorrelation does, it removes all the static areas from these images. So it only shows what's moving in the images, which is the red blood cells flowing in the blood vessels. And then it generates this OCTA image of the red blood vessels flowing within the blood, within the vasculature. So OCTA has required some new terminology. As I said, B scan is a cross-sectional OCT, but the C scan is looking at the image parallel to the retina surface. That's also called the en face image. And we also talk about segmentation, which is separation into different en face layers, where a slab is a thick tissue section and a slice is a thin tissue section. And registration means correlation between the B scans and the en face C scans. So the amazing thing OCT and OCTA is it gives us correlation between structure and flow. And all the machines that give us OCT angiography, OCTA, will also give a structural OCT. So this is a patient with a history of central serous with a questionable RPE detachment on exam. Here we see the color fundus photo, and here's the fluorescein. And the question is there choroidal neovascularization on the fluorescein? Here we can see the OCT-B scan. There's this double layer sign, which is a relatively flat fibrovascular PED. And the OCTA shows that there's choroidal neovascularization in this region. Also, the OCTA can let us do something called flow overlay. It takes the regions of flow from the OCTA and puts them on the OCT-B scan. So we see these red regions corresponding to flow in the bottom left image, confirming that there's flow in the region where the choroidal neovascularization is. There have been a lot of correlations between fluorescein angiography and OCT angiography. There's also a lot of differences in the machines that are available. And what I would say is it's really important to be aware of the parameters that your machine provides in order to understand the images. So I'm just going to quickly show you some of my areas of interest and what I think has made OCTA valuable. And we did a project where we used OCT angiography to distinguish IRMA from retinal neovascularization in diabetic retinopathy. And IRMA is a really key point in diabetic retinopathy. It defines severe non-proliferative diabetic retinopathy. And IRMA stands for intraretinal microvascular angiography changes, so IRMA. So it's such a critical point. At 50%, once you have the presence of IRMA, there's a 50% chance of progression to proliferative diabetic retinopathy within 1 year. So sometimes IRMA can be difficult to characterize with fluorescein angiography. It might show a little subtle leakage and be confusing and look a little bit like retinal neovascularization. Also, it's time consuming to do fluorescein to look at these patients. So for that reason, it would be useful to characterize IRMA with OCT angiography. So we did this paper to evaluate the differences, and we prospectively evaluated a series of eyes with proliferative and severe non-proliferative diabetic retinopathy. And what we did is we used multiple wide field images that we mosaic together to make an image like this, and identified regions of vascular abnormalities and correlated it with the fluorescein angiograms. And we use this called the flow overlay, where the flow in the OCTA image is put onto the structural OCT, and the red region characterizes flow. So what we found was that here, for example, is a region of IRMA that was seen on the fluorescein angiogram. And we looked at it on the OCT, and then we looked at it with the structural OCT with the flow overlay from OCTA. And we found that IRMA is confined intraretinal flow with a core of flow with outpouching of the internal limiting membrane, but it didn't break through the internal limiting membrane, and it was often surrounded by adjacent capillary non-perfusion. Here's a patient. We can see this region. It's a little bit leaky on fluorescein. And if we look in that same area with OCTA and OCT with flow overlay, we see it's consistent with IRMA. There's no neovascularization in that area. What about retinal neovascularization? So here's an area on the bottom of definite retinal neovascularization. The top image shows the OCTA, and then we look at the corresponding structural OCT with flow overlay. We see that there's flow above the retina, supraretinal flow that breaches the ILM and extends into the posterior hyaloid, and it often had a wider core. So we were able to use OCT angiography and the corresponding OCT with flow overlay to really characterize retinal neovascularization and differentiate it from IRMA. Here's a case where the patient had neovascularization with some fibrosis, and we could still see the breach through the ILM, but there was less prominent supraretinal flow. There were a few cases where the fluorescein and the OCTA mismatched. It did have a lot of specificity, 99%, and a sensitivity of 92%. And we thought that maybe the mismatch was due to some fibrosis or transitional phases or other sources of neovascularization beside IRMA. We also used OCTA to characterize different types of IRMA and give it description and look at IRMA and describe what happened to IRMA after anti-VEGF injection. And we described multiple IRMA patterns: dilated trunk, loop, twisted loop, a C-fan shape, and we looked at what happened to IRMA after anti-VEGF therapy. And I think the important thing to note is that we found a whole host of things happen after anti-VEGF therapy. There was regression of some IRMA. There was a little bit of improvement in non-perfusion in some eyes, but in some eyes, IRMA continued to progress despite anti-VEGF therapy, or they remained stable, or in some cases obliterated. So I think that there's a lot left for us to understand about IRMA and the response to anti-VEGF therapy and what happens with non-perfusion. And this is the last paper that I want to mention. This is a patient looking at wide field OCTA for detection of proliferative diabetic retinopathy. And again, we use the vitreoretinal interface slab. You can see there's neovascularization here. And we found that we were able to detect neovascularization of the disc and elsewhere using multimodal imaging with color fundus photograph and OCT and OCTA, and we're able to characterize neovascularization elsewhere and on the retina and use this to diagnose proliferative diabetic retinopathy. The other area where Oct Angiography has been really useful is looking at eyes with macular degeneration. And here's a patient I saw in 2013, and she had drusen in her right eye and choroidal neovascularization in her left eye. And she had one anti-VEGF injection. She got better, and she never came back until 2017. And she was actually stable at this time. She just decided to come back to have me look. You can see in her color fundus photo, she has some drusen, and this is her OCT. And we had Oct Angiography, and I was really surprised. Her right eye, which never had an anti-VEGF injection, had choroidal neovascularization. And her left eye also had choroidal neovascularization, but there was no fluid, and she'd only had one injection. So this brings up a whole host of things that we found now. Now we know that there are patients who have non-exudative choroidal neovascularization. And there are patients who have choroidal neovascularization in other entities we didn't know. And there are patients who have what look like drusen or large PEDs, and they actually have choroidal neovascularization that was unsuspected. Here's another case where OCTA was interesting. This is a patient that looks like they have a branch retinal vein occlusion, but you can see it doesn't follow the horizontal raphe. So it goes above the horizontal. And here, just an OCTA shows that there's neovascularization above the horizontal raphe. And actually, this was radiation retinopathy. So I think OCTA can give us a lot of valuable information that we weren't getting before. And lastly, OCTA is very helpful to look at the choriocapillaris, which now is being really evaluated to understand the pathogenesis of AMD. And this shows a multiple stitched image of OCTA. So I kind of went through a lot of information quickly. I think retinal imaging plays a key role in all of our patient management. And we're so fortunate in retina that we have this sort of technology that they don't have in other fields of medicine. It's going to play a big role in us having new therapeutics. And we still have a lot of ways to go. Like we get a new, smartphone every year. The technology for OCT and all of our other retinal imaging is going to take off just in the same way. We're going to have higher definition, faster, non-invasive imaging. I think that we have everything. We have all the pieces to have amazing telemedicine in Retina, which will help us screen our patients, especially as the elderly population grows. We have amazing technology, and we have all of this multimodal imaging that will help us better serve our patients. All right, thank you. Let me just.
Thank you.
Rodrigo, may we ask some questions?
Right,
Yeah.
no question is an
Sorry,
issue.
I went through that kind of quickly, and I usually do a more conversational thing, but I had a lot of slides, so please ask any questions.
Okay. Caroline, thanks a lot for your fantastic lecture. Actually, and thanks also to receive our fellows in your service. We're very thankful for your kindness, okay? Actually, I would like to make you two questions. There are a lot of fellows here listen your talk, your fantastic talk. I have two questions for you. One, do you think the OCTA is able to replace the fluorescein angiogram, especially for the management of proliferative diabetic retinopathy? Because people that are starting in the market job, they have, I would say, restricted budget in order to buy these fantastic devices. My first question should be this. And the second question is, which kind of OCT would you do your investments as beginning your career in ophthalmology? Swab source technology or spectral domain technology? Two questions.
Well, that's a loaded question. I think that, the real thing is the cost. I mean, you hit right on that. And I can tell you that, like, in this country, in the States, you can't bill more for doing OCT angiography. There's a cost for OCT, and if you do an OCTA, you can't bill the patient for like a more complex level imaging. It's the same price. And that is why it has been not picked up as much here, because people have their spectral domain device. They don't want to pay if there's no reimbursement for it. And they already have fluorescein in their office. So it doesn't, even though it saves time, and I think for me, like I barely do fluorescein anymore. There has to be, some sort of system to compensate, because the machines are very expensive, although the price has really gone down. And I think over time that, it will pay for itself, like all of these things. In the United States, you can't get the Plex Elite Swept Source OCTA unless you're part of a trial, but I would think it's different where you are, right? I think you probably have more access to it.
We have the top cone.
Yes, we have the top.
We had that briefly, like we trialed it many years ago, and it's probably better now. But I like the TopCon device that we trialed could do multimodal imaging, which I thought was great. I think that I barely use fluorescein angiography, and I don't use it to make diagnosis so much of proliferative diabetic retinopathy. I make that diagnosis when I examine the patient, and I use OCTA, and I use like a wide field color fundus photograph to help me make the diagnosis. But when I do use fluorescein, I use it more for things like white dot syndromes, or because I want to do fluorescein with ICG to look for, unusual central serous or white dot syndrome. I don't use it so much for proliferative diabetic retinopathy, except in cases where I've treated a patient and I'm just not sure if the blood vessels are still leaking, like if it's still active and I want to stop treating them, or the patient wants to stop treatment. So those are the times I use it. I'm a big fan of OCTA. I would say any device that does wide field OCTA, or that is going to be updated to do wide field OCTA would be useful. And when I see a patient, if I'm seeing a diabetic, I do a 3 by 3 millimeter OCTA to look at the fovea, and I do a 15 by 15 OCTA. That's my newest protocol. And if I'm seeing an AMD patient, I'll do a 3 and a 6 millimeter OCTA. So I don't want to like endorse a specific company because I think that they all have pluses and minuses. But I it's tough because you want to buy something and then like the technology can change so quickly. You want to buy something that they're going to keep up to date, or the newest version, or something that's going to be upgradable with software only. But I do think it's useful, and it saves me a lot of time to do OCTA. And really, I do OCTA in almost all of my patients.
Okay, so thanks. I think I agree with you that OCTA is the future, as is the present too. True, but however, fluorescein angiogram and also ICG in some cases are important in order to treat some specific kind of patients, right?
Right. I had a patient once. It wasn't my patient, and this was about 10 years ago, but I still remember. It was one of my partner's patients, and she had geographic atrophy, and she had nude distortion. And she came in, and my partner said, "Can you get a fluorescein?" I wasn't going to get one. I did an OCTA. She looked okay. I thought the distortion was from progression of the atrophy. But the person asked me specifically, I want a fluorescein. So I did the fluorescein, and I'm seeing patients, and I walk out of the room, and I see my fellow, and she was like 7 months pregnant. And she's sweating, and she's like, looks really bad. I'm like, what's going on? So she goes, oh, the patient had a heart attack. So I go over, and there's like, we're in a hospital. There's all these people around the patient, and an anesthesiologist, and someone's running a code. And I said, it's anaphylaxis. She didn't have a heart attack. Get the EpiPen. And the anesthesiologist looks at me, is like, you don't know what you're talking about. People, he wasn't familiar with this. Anyways, you lifted up her shirt. She was covered in hives. She had anaphylaxis, and they gave her the EpiPen, and it's like something in a movie. She just like opened her eyes and popped up. Anyways, so she was fine. She was like 92, but like a good 92. And after that, like just seeing my fellow who was like pregnant she must have been doing CPR on the lady. I was like, you know what? There are risks from fluorescein. You'd be lucky if you never see someone have anaphylaxis, but you do have to, like, if you do fluoresceins and you have a private office, you have to always have an EpiPen. You have to have people who know to get you right away if there's a problem. Like if they had come to get me right away, no one thought of coming to get me. I was the most experienced person there. So you do have to be aware and prepared to manage these things. And, you might not have the means to manage that in your office.
I think Renato has a question.
Yeah, in patients that underwent PRP, does the OCTA decrease in utility due to artifacts in the mid-periphery? It certainly is. It is harder to interpret the OCTA sometimes. I don't think it's so much artifacts. I think the artifacts a lot depend on the patient. But the real thing is when someone has PRP, the neovascularization can still be there, like we showed with fibrosis. It's still there. It just might be less obvious, but you don't know dynamically. You don't know if it's still leaking or if it's barely leaking. I think that's the issue in patients who've been treated, or if they've had anti-VEGF, it's harder to tell. But for me, I don't think PRP affects my imaging so much.
Does anyone has any questions?
let's see some cases.
Yeah, sure. So just one more quick question, changing subject, Caroline. Yeah, I've seen that you've written a paper about complications of brolucizumab, the vasculitis, occlusive vasculitis. Brolucizumab is going to be available for us this year. So could you share with us any hints about treatment of those patients? What could you say about it?
Well, I'm happy to come back also and talk to you about brolucizumab, actually, because I do have some talks on that. But I was involved in a series of, we put together a series of patients who had some complications after brolucizumab became commercially available here. And I think it's rare, but there are cases of occlusive retinal vasculitis and inflammation after brolucizumab. So they looked at previous data and classified it. Some patients can have intraocular inflammation, and typically most of these eyes are treated with steroids and they get better. But some patients have inflammation with retinal vasculitis and with occlusion. And if the occlusion happens in a vessel at the optic nerve or the macula, there can be vision loss. I think that it's under 0.5%. It's rare. We still don't know why it happens. You know, the company is actively working on trying to figure out what the etiology of this is. In my experience, brolucizumab is a very effective drying agent in the patients that I used it in. And I would say that if you see a patient who has inflammation after brolucizumab, of course, first rule out endophthalmitis. That is number one. And then after you have ensured that that's not it, examine the patient very carefully and look at the peripheral retina, because the signs of occlusion can be very, very subtle. And this is a case where fluorescein may help. We actually did an OCTA in our patient who had occlusion after brolucizumab, and it did show changes, but fluorescein is also very helpful to show very subtle occlusive vasculitis. And I would say that if you see any patient who has inflammation or occlusive vasculitis, I would treat them very aggressively with oral or intraocular steroids. I think if they just have some inflammation, you can most likely treat it with topical or subtenons. And we wrote a paper about this, but you have to follow them very, very carefully. And if they develop any occlusive vasculitis, I would treat them with systemic or intraocular very aggressively.
Thank you. So let's move on the clinical case. Mariana, Dante, you can show the first one.
Yes.
Doctor, can I just ask a question before we move on? Yeah. My name is Ira. I'm a first-year fellow here. And you comment, first, your presentation was very clarifying, perfect, captivating from the beginning to the end.
Thank you.
And you commented about OCT during surgeries and the intraoperative moment. Do you use it as a helpful tool during your surgeries or only maybe in specific cases? How do you see the
Well,
OCT?
I like to look at the OCT before I do the case. There's going to be technology where you can have the OCT, like, you know, if you're using a 3D, like an Ingenuity, or there's a new device that might be available called Bionics, which is a VR surgical device. You might even be able to look at the image, the OCT image right there as you're doing your surgery. And of course, there's also intra-op OCT, but I like to look at it right before I do the surgery. And then it just helps me gauge how tight the membrane is. We recently switched from ICG to membrane blue here. We didn't have that available before, and you get this kind of reverse kind of imaging, the reverse kind of staining from the ERM. So I think it helps me just look and see where there's a space between the ERM and the retina and where to pull. But I always look at it. And I'm surprised, even some detachments that my fellows see, we take them to the OR and they have a macular hole. We just did one yesterday. It wasn't seen pre-op because the retina was so bullous. So if I can get an OCT image, I find it helpful.
Okay, thank you.
You're welcome.
Can you see my screen?
Perfect.
Okay, good morning. My name is Dante. I'm a fellow from Retina and Vítreo's division. I'm going to present the first case of this morning. So this case is about a 25-year-old male patient born in São Luís do Maranhão and living in São Paulo. He complained about a low visual acuity in his left eye with progressive worsening in the past 2 months. He was first evaluated at our emergency room. He presented an IOP in the left eye of 40 millimeters of mercury. It was introduced timolol, brimonidine, and travoprost. And he was referred to our retina division to evaluate some fundus alterations in both eyes. His past medical and past familiar histories were unremarkable. The ophthalmologic exam, his best corrective visual acuity of the right eye was 20/60, and in the left eye was counting fingers 1 meter. He has a myopic refraction of -2 in both eyes. His IOP was 18 in the right eye and 20 in the left eye. The gonioscopy was showed an open angle with normal pigmentation in both eyes, and the anterior biomicroscopy was pretty normal. The fundus exam of the right eye, we can observe a pink optic disc with sharp margins, a cup to disc ratio of 0.2, so, papillary atrophy, and we can see this RPE and mottling in the around the disc and in the macula, and this we can observe this yellowish lesion in the foveal area and some pigment deposits. The periphery, the mid periphery, and the far periphery was normal. And the fundus exam of the left eye, we can observe a pink optic disc with sharp margins, a cup disc ratio of 0.9, almost total, a peripapillary atrophy, and the same pattern of RP mottling around the disc and in the macula with some pigment deposits as well. The mid periphery and the periphery were normal. So for the diagnostic hypothesis,
Is this for me now? Well, I would like more imaging before I give my hypothesis, but I think it's when you look at someone like this, you just want to, why did this patient lose vision? The right eye, the patient's not complaining about the right eye, correct?
yes,
So
he didn't have any
this
complaint.
patient lost vision probably from glaucoma because they're really cupped out. I don't know if the macula, I haven't seen the OCT yet, but you're going to show me whether it's a macular problem that he lost vision, or are his retina changes chronic and he just lost vision because of his pressure and his optic nerve cupping, which it kind of looks like to me. So I don't know if this is an active problem or an old problem. I think OCT and angiography will help you define whether it's active or old and why the patient lost vision. And I think that would be helpful. You know, you want to, if it's inactive, you want to consider whether it's an infectious inactive process that the patient had before. It is a little bit symmetric, so you'd want to consider whether there was a genetic process going on. He did have high pressure in his eyes. You said there was no cells in the eye, but there's some things that can make high pressure, like, ARN and toxo, those can all cause like hypertensive issues in the eye. So I would kind of probably look at like an inactive infectious thing and whether this was a genetic thing first before but I would get more imaging.
Okay, I'm gonna show the multimodal retinal imaging. So just to show our hypothesis, we divided into inflammatory causes, infectious causes, hereditary causes, and other causes. And it's more the same as Dr. Caroline said. We think about Azor and serpiginous choroiditis as inflammatory causes. For infectious causes, toxoplasmosis, syphilis, tuberculosis, and for hereditary causes, we thought about pattern dystrophy, maybe in an adult onset vitelliform dystrophy, and other causes just to less likely in CRA and MRA or torpedo maculopathy. So the management, we asked for the multimodal retinal imagings, and we also asked for laboratory workups, serologies, tuberculin tests, and the glaucoma division, they performed the 24-2 visual field and nerve fiber layer OCT. The fundus autofluorescence of the right eye, we can observe these hypoautofluorescent lesions around the disc and in the macular area, and this hyperreflect lesion in the foveal area. Hyperautofluorescent lesion in the foveal area. The fundus autofluorescence of the left eye, we can observe these hyperautofluorescent lesions around the disc and in the foveal area. The fluorescent angiography of the right eye, we showed some hyperfluorescent areas around the disc and in the macula with some hypofluorescent lesions here due to the blockage of the pigment. In the later stages of the exam, we can observe the staining of the yellowish lesion in the fovea. And the left eye, the angiography, we can observe the same pattern of hyperfluorescence areas around the disc and in the fovea. And the OCT of both eyes, we can observe the posterior vitreous detachment, and in the ellipsoid zone, we can observe some disruption in the foveal area and increased choroidal thickness in both eyes.
Mm-hmm.
And I'm going to show the foveal area of the right eye. You can observe this hyperreflective material in the subretinal space with disruption of the EZ zone.
Well, I think that's kind of interesting. That looks a little bit more like a vitelliform lesion. So, okay.
And here's we also performed the OCT angiography of the right eye. You can observe in this neovascular complex in the outer retina with some flow inside this hyperreflect material.
See, that shows the utility of OCTA. I mean, clinically, it looked mostly like a scar and it didn't stain that much, but there was a great paper by Eric Syed, and they looked at patients with scars and they found a lot of flow within them. So this is more flow than I would expect to see based on the fluorescein, and I think that's interesting.
The face OCT and the OCT angiography of the right eye was unremarkable. So the systemic evaluation, the complete blood count was normal, the urea and creatinine were normal, CPR was normal, the serologies for HIV, syphilis, and tuberculosis all came negative, and the tuberculin test was 5 millimeters. So, and the glaucoma exam, the visual field of the right eye, we can observe this paracentral central scotoma in the total deviation, but it disappeared in the pattern deviation. And the nerve fiber layer OCT of the right eye, we can observe nasal thinning. And in the left eye, we can observe a global thinning of the neuroretinal rim. So now I'll go back to the diagnostic hypothesis, so we can discuss with the multimodal retinal images and the systemic evaluation.
Dante, I just want to ask you one question. How long does the patient complains of lowering of his visual acuity?
He couldn't say exactly how many months or years. He didn't know. He just realized that 2 months ago he started with a progressive worsening of his visual acuity of the left eye. He didn't complain about low visual acuity in his right eye.
Okay.
Well, I think he lost vision in his left eye from the glaucoma now. It probably just had high pressure and it peaked and something put him over the edge. But you know, otherwise his eyes, the appearance is so symmetric that I would say I don't think it's an infectious cause, and it doesn't really look like serpiginous to me, but it's hard to make that diagnosis without seeing an active lesion. It doesn't so much. And I would probably, you know, evaluate him for a hereditary cause. To me, that seems more likely. Something like, you know, vitelliform macular dystrophy, or it could be, I have been seeing some of these patients and they come back and have the best gene defect. So that's probably, and in the States, you can send people for a spit test from a company called Invitae. They actually do it now for no charge for a patient who has ocular problems, and we get back a lot of really interesting results. Some of them don't know what it means, but so I want to hear what you guys thought.
Yeah, I agree with you. It looks like some hereditary retinal disease. One thing, inflammatory disease, I could possibly think of AMPI, a heel AMPI, but the history of the patient, it seems like he has this problem for a long time, and he has a scar in the right eye, probably something from the past, and the glaucoma was the cause of his left eye vision loss. So I think hereditary disease would be the first in the diagnosis as well.
The other thing I was wondering, maybe he had a history of maybe VKH in the past or something. He did have a really thick choroid, but it doesn't sound like he did based on the history.
He didn't have any systemic complaints like headaches, tinnitus, or previous systemic symptoms.
Right.
Dr. Caroline, what would you do next for the investigation of the hereditary causes?
Well, I would send him for a spit test because it's free. I wouldn't treat the right eye with anti-VEGFs. It looks like it's not leaking, but I think some people might. I would watch that very carefully. And maybe if I ever image the patient again, I would probably do an ICG just to see if I saw any active lesions, if it could add something to it. Someone wrote something in the chat about VKH. Like the fluoresceine's not typical. It's not exactly typical for VKH, but it can be a difficult diagnosis to make, and it can cause high pressure. That's the other thing. If you have inflammation, but you said there was no inflammation in the eye.
Yeah, actually, Dante, I would suggest in this case electrooculogram and also ERG in order to help us to understand better the function of the retina. And I agree that the left eye, we have a confounding factor that is related to the loss of vision in consequence of the glaucoma.
I think that's it.
Okay,
Great
thank
case.
you. Let's move on to Mariana now. Can show her the case.
So good morning, everyone. Sorry, just are you seeing my screen?
Perfect.
Okay, so hello to everyone. My name is Mariana. I'm a third-year resident here in our service. So I will present today a clinical case, the second one. So I introduce to you a female patient with 30 years old, Asian descendant from Porto Velho, Rondônia, and she was a lawyer. Her chief complaint was a progressive low visual acuity in the right eye, 1 month. And the history of present illness, the patient referred a progressive central low visual acuity in the right eye for 1 month. She had headache and photopsy were associated at the beginning of these symptoms, the ocular symptoms. And she was in treatment for Behçet disease with oral prednisone and azathioprine. And this was guided by the primary physician after a laboratory workup with the HLA B51 positive. In the past medical history, she denied oral and genital ulcers. The patient reported an episode of gastroenteritis 1 month prior. The past ocular history and the past family history were both unremarkable.
So if she had no ulcers, why did they make the diagnosis of Behçet's? Do you know?
Exactly, doctor. I think with the fundus and the fundus exam that I will show, and also this complaint of the visual acuity low, they start this treatment, but I will talk this point that you told just now in the sequence of the presentation. So in the ophthalmologic exam, her visual acuity in the right eye was counting fingers with no improvement with correction, and 20/20 in the left eye with correction. The anterior biomicroscopy in the right eye had no anterior chamber reaction, but had 1+ in 4 of Vítreo cells, and the anterior biomicroscopy of the left eye, no alteration were seen. The intraocular pressure at 11 p.m. was 19 in the right eye and 18 in the left eye with the gold tonometer. The right eye had +2, direct and consensual pupillary response, but no alteration in the relative afferent pupillary defect. The left eye had +4 in 4 and consensual and direct pupillary response. The right eye had no response to colors, and I will show the fundoscopy photos of the both eyes. So here we have in the fundoscopy of both eyes a pink cup to disc with the sharp margins, the cup to disc ratio of 0.5 in the OD and 0.6 OS, normal vessels, and tatted retina. Related to the macula, if we look with attention, we can see a hypopigmentation of the RPE in the red square in the right eye when we see by comparison with the left eye, and the peripheral retina was normal for this patient. So with this history and the fundus examination, I would ask, what do you think about the diagnostic hypothesis? I know I will see other exam, but just to elucidate a little bit.
You have to make the diagnosis after I see the OCT. I think that, so it's primarily one eye, right? The left eye you said was normal.
Yes.
And had a headache, and she's HLA B51. I guess that's why they made the diagnosis. And did you say she had iritis and uveitis? Sorry, my dog wants to watch.
That's okay. She had some vitreal cells, no anterior chamber reaction, but vitreal cells. So we think there was an inflammatory component.
Right. So I would think about things like, oh gosh, I would think of things like also like inflammatory things. Hold on a sec.
That's okay.
My dog is barking at the mailman. I'm not kidding. I would think of inflammatory things. I mean, maybe they just had the wrong inflammatory thing, AMPI and VKH because she had a headache. But there's other causes of vasculitis that can cause us multifocal choroiditis. It's interesting where you showed where the changes were in her right eye, because often you see changes in pigmentation there and things like AMN, which is something I showed you, but it's usually bilateral.
Okay.
So I would really want to see an OCT, and probably a fluorescein and an ICG.
Okay. So just to summarize, we have this case with a 30 years old female patient. She had this low visual acuity, the vitreal cells, and the RPE hypopigmentation.
And of course, we got to roll out syphilis and everything. I forgot to say that.
Yes. So he made the syndromic diagnosis of unilateral posterior uveitis. Thinking about the infectious, we think about syphilis, the acute syphilic posterior placoid chororetinitis. And the inflammatory causes, we prioritize here the acute outer retinopathy, the acute posterior multifocal placoid pigmented epitheliopathy, and the persistent placoid maculopathy. And we speculated about this BC disease, and just to highlight that there is no fulfillment of diagnosed criteria in this case for BC disease.
Mariana, may I ask you one question, please?
Yes.
Yes, actually, you haven't seen any kind of ulcers, or neither ulcers or nor hypopion, right?
Yes, that's right. She denied the ulcers.
No hypopion and no ulcers, right?
Right. That's right.
Okay, thank you.
It's interesting you have Azor in the last case and this case. I will say I see a lot of patients. I have only seen Azor twice. And they're both actually in young people, and they both had that kind of white line that they talk about. And then they never came back for follow-up. So I think it was Azor. I followed them for about a year and they never came back. So I'm assuming they got better. So, but it's pretty uncommon, I think.
That's true. Okay. So the management in this point, we asked for a previous medical report and exam from this first appointment that was not with us. So we saw her 1 month after the beginning of the symptoms, the first time that we saw her. And based on the diagnosed hypothesis, we also asked for laboratory exams for syphilis and a multimodal ocular imaging to see. The primary physician appointment related a 1 week history of low visual acuity in the right eye. At that time, the visual acuity was in OD 2050 and OS 2020. The fundus exam was normal, and she had this syphilis not reactive test. So related to the ocular imaging, I will show first the OCT. So here to start, the OCT from this first appointment, it's possible to see in the right eye a disorganization in the photoreceptor layer from the disc until the fovea, and also an irregularity of this ellipsoid zone. Next, 1 month later, we can see a progression in this disorder in the outer layer of the retina and a subretinal hyperreflective material in this dome shape here. The second exam, the fundus autofluorescence, we can see here in January and February exams, autofluorescence in the papillomacular bundle here. And for the fluorescein angiography of the right eye, in February, there was this hyperfluorescence pattern. This is small areas of hyperfluorescence areas that appear early and remain until the later phases of the angiograph. And the fluorescein angiograph of the left eye in February with no alterations. And related to the fundoscope image, we can see for the right eye in the beginning, these normal fundus in the first appointment, the RPE hypopigmentations in the papillomacular bundle in the second time, and subsequently these pigmented alterations in the macula here. Also important for this case, I would like to show you this electroretinogram. First, this multifocal showing the reduction of cone response in the macular area of the right eye. And the second, this full field that demonstrate the delay of rod's response in the right eye, although the amplitude of the rods are between normal limits. When we compare with the left eye, they are reduced. And so I would ask now, what do you think about the diagnostic hypothesis?
You didn't do an ICG, did you?
No, I'm sorry, I don't have the ICG for this case.
I don't think the fluorescein was like really typical of AMPI actually, even though the CNS stuff and kind of the ellipsoid loss was a little bit more. Someone asked in the chat about Duzen. You know, I usually see people with Duzen, they have so much more, they look so much worse than this. So I think it's unlikely. Can you go back to the OCT for a sec?
Of course.
My view was not great. So in this picture, she looked like she was getting a little bit better than the one before. Is that right? Like here, there's more ellipsoid loss, maybe?
Yes, and here more hyper-reflective, maybe some here in this area here, the material.
Well, I would say maybe she has a placoid disease, but I don't think that this is AMPI, which is what I thought it might be originally.
Yes, so we thought about the Azar for this case. We thought this as a final diagnosis. We are seeing the patient, thinking about it. So in the follow-up, she remained with this oral treatment. We looking for in literature that there are no treatment of reading value for Azar until now, but some retrospective studies pointing to corticosteroid therapy, even so for studies are necessary. And there was no alteration in this visual acuity until last evaluation, so the patient remains with low visual acuity in the right eye. But we maintain this continuous follow-up because we know that a high percentage can have bilateral involvement in the sequence of the disease.
I think it would be important to make sure she doesn't have like a brain vasculitis or something. Like she didn't have any vasculitis on her fluorescein or anything, but just the fact that she had headaches, you might want to do some CNS imaging.
That's okay. So we can exclude this option. Yes, I think a point that was important for us to think about Azar was this this reduced response of cones and rods that we see in lateral retinogram with so So we don't have a lot of signs in the fundoscopy, and that can have this low visual acuity, this deep low visual acuity. So
Mariana,
with
could you please go back to the fluorescing angiography?
yes.
So here we can see some subtle alterations. I don't know, I could see some rings close to the superior temporal artery. I think that this might be a case of mutes that develop like a Azor-like complex. But there's some missing signs for you to say that this patient has Azor. The line that Caroline was mentioned about is you usually see, and you usually see as well some atrophy of the outer nuclear layer in the region that you have the loss of the ellipsoid zone. So I think it's like probably he had an inflammatory disease and developed this loss of photoreceptors, and it's kind of stable, but improve it at the first couple of weeks, because you can see the ellipsoid zone with better resolution. And this hyper autofluorescence, it's related to the loss of the ellipsoid zone. So you can see the autofluorescence of the RPE better where you don't have the ellipsoid zone. That's my opinion.
Yeah, you often see that kind of wreath on the fluorescein and mutes. To me, this doesn't look so much like Azor, but you know, as I said, I've only seen it twice. The one
but that's perfect. It's because of this discussion that I bring this case, because it's a difficult diagnosis. So it's good to hear what do you think about it.
I don't think it's mutes right now, but probably it had mutes in the past, in the beginning of the case. That's my thought.
Yeah.
Yes, Mariana, I would like to point out one important thing. Actually, someone asked about Tuesday, right? Which is very common in Brazil. Tuesday normally is a unilateral disease, and we may have a hot spot in the optic disc in these cases, but normally is unilateral in the first clinical features of the disease. So I think this patient, I agree with Rodrigo. I think this patient had some viral disease, which can be mutes or a variation. And for these, when you do the fluorescent angiogram, you see some leakage, very, very small leakage. I think it's hot, the optic disc in the end of the fluorescent angiogram, which is a clue that this is a tip of that this patient had a viral disease. And for the consequence of this, you have problems in the cones that you can observe in the electrophysiological tests. For me, because of the cellularity of the disease and the heat observation of the fluorescent angiogram over the optic disc, I would start this patient after excluding all the infectious disease. I would start with the prednisone, where I think it's important, 1 milligram per kilo in the next month, and would observe the evaluation of this case, the evolution of this case. Okay.
That's okay. Thank you for the comment.
Well, the one thing with mutes is that they often get better. So, you know, sometimes in these entities, it's hard to tell. There's a little bit of overlap between different things. And so if she gets better, you will have more information.
Yes, actually, I saw this patient 1 year ago, and she remains with this low visual acuity. So it's a little hard to know now, but we are gonna keep the follow-up with her to see what happened. And I'd like to thank you for your comments and tell you that your lecture was amazing, was very clarified for us.
Thank you.
Thank you for you.
Good morning. Can you hear me?
Perfect.
Okay. So, good morning. My name is Juan Huelco. I'm a second-year resident, and today I will present this grand round case, this retina grand round case. My preceptor is Dr. Renato Passos, and the head of division is Dr. Rodrigo Brandt. And I bring this case of a male patient, 11 years old, an Arab descent. He complains of black spot on visual field on both eyes for the last 15 days. And for the past...
And my diagnosis, laser pointer.
And
Am I wrong?
I don't know yet.
Go on. That's just my diagnosis. I have 11-year-old twins. That's why I said that. Okay, go on.
I don't know the case. Let's see.
That's a good hypothesis. And for the part of ophthalmological history, he denies any previous trauma, surgical procedures, or any other kind of treatment, and no remarkable past medical history, and either family history, just a mother with myopia. And ophthalmologic examination showing visual acuity with pinhole of 20/20 on the right eye and 20/40 on the left eye, with the slit lamp examination without alterations, and applanation tonometry of 12 millimeters of mercury on both eyes. And the fundus exam here showing on the right eye with a pink optic disc with a capture disc ratio of 0.2, normal vessels, and this subretinal white yellowish nodular lesion in the perifoveal area with some edematous retina around. And here on the left eye, we can see a pink optic disc, capture disc ratio of 0.3, and a little bit of increased vascular tortuosity. And then we can see this lesion, this subretinal yellowish material with edematous retina around as well, with this fluid level here. So here...
Would you go for the next slide, last slide?
Here, this?
Okay, okay. I have a hypothesis.
Yeah, so can we hear from you, doctor, please? What?
Okay, so it wasn't a laser pointer, but I'm just thinking about my 11-year-olds and losing vision. That would be a laser pointer. Well, I think the history is kind of interesting. He lost vision in both eyes for 15 days.
That's what he said.
That's what he said. I would ask about a family history of eye problems. And I think, again, you have to rule out something, whether look into genetic causes, evaluate for something like BESTs or something that imitates BESTs. But I would also do an infectious workup. I couldn't tell from if someone just had the right lesion alone, you'd want to make sure that wasn't like subretinal infectious etiology. Not based on the left eye, it doesn't look that way, but I think those would be my two big things. And an OCT would be very helpfful here.
Yeah, very well said. Yeah, sorry.
Actually, what I believe, I agree with Caroline. I believe the first hypothesis for me is BEST disease in an atrophic phase in the right eye, in a disruptive phase in the left eye. This should be my first hypothesis. I would ask for ERG and also electrooculogram, EOG, in this eye to observe the ardent index in this eye. Okay.
Yes. Perfect. And then so we can see that we have an 11-year-old male patient with low visual acuity on both eyes, and without any remarkable past medical ocular history, and with this fundus examination. And so we can think as a exudative maculopathy on both eyes as a syndromic diagnosis. And then we can think of etiologies like infectious, like toxocariasis, syphilis, and tuberculosis, as inflammatory like sarcoidosis, and hereditary like Best vitelliform macular dystrophy, pattern dystrophy, Stargardt, and cone dystrophy, and tumors like metastasis and intraocular lymphoma. So for the workup, we could ask for ancillary exams like retinography, fundus autofluorescence, macular OCT, OCT angiography, as Dr. Mauricio said as well, electrooculogram, and genetic specialty consultation. Here we can see in the fundus autofluorescence, we can see hyper autofluorescent round lesion here on the right eye, and the left eye as well with this fluid level. And here in the OCT on the right eye, we can see subretinal fluid with hyperreflective cupuliform lesion here under the RPE. And for the left eye, for the OCT angiography, we can see this hyperreflective material here in the deep retinal layers, corresponding to the cupuliform lesion that I said on the OCT of the right eye. And here in the left eye, we can see a macular edema with subretinal fluid along with this vitelliform material here. And for the OCT angiography, we can see the same material here on the outer surface of the retina. So for the diagnostic hypothesis, we thought of Best disease, as Dr. Mauricio said, for the right eye and the disrupted phase of scrambled eggs, and for the left eye on the pseudohypopion or vitelliform phase. And this can have some discrepancies on literature, but we thought on this hypothesis. And then for the management, for the right eye, we thought on observation with close follow-up and refraction. But then in the follow-up for a case, the patient lost these consultations because of the COVID pandemic, and he returned 1 year later for evaluation, complaining of worsened visual acuity in the left eye. So we can see here in the left eye a loss of visual acuity in the with pinhole of 20/200. And this patient showing here in the fundus exam, we can see that the right eye has this round lesion with round edematous retina round, and the left eye with this yellowish lesion like a fibrous scar. And here in the right eye, we can see subretinal fluid with with this cupuliform lesion here, and the left here in the right eye we can see perifoveal hyperreflective lesion suggestive of neovascular membrane here in the right eye. And here in the left eye we can see this hyperreflective material suggestive of fibrotic scar, and the macular area with mild cystoid macular edema. And here we can see the same image with central blockage on the OCTA, suggestive of fibrotic scar here, and the end phase image as well. So at this point, we thought about a subretinal neovascular membrane and the right eye associated with Best disease, and a fibrotic scar on the left eye. So we tried an anti-VEGF on the right eye and observation in the left eye. And so for the follow-up in the first and the third and the fourth months after the anti-VEGF injection, the patient remained with the same alterations on the OCT with a similar visual acuity on both eyes. We can see the same patterns of the OCT after the injection. And 6 months after the injection, we can see here for the right eyes keeping the same pattern and the autofluorescence as well. And here on the left eye, the patient didn't refer any changes, but here we can see in the left eye that the patient presented with this hemorrhage inferior to the lesion, to this round lesion. And in the fundus autofluorescence, we can see the hypoautofluorescence lesion here, suggestive of hemorrhage. And then on the OCT, we could see for the left eye that there is this cystoid macular edema over the lesion of the fibrotic scar, suggesting a reactivation of the subretinal neovascular membrane. And then for the management, we did an injection for the left eye of anti-VEGF. And this was the last update of our case on March 2021. And the patient keeps on following up.
Yes, actually, I would like to make one point before our international guest says something. But I think it's important for people who are starting in vitreoretinal diseases that some patients with best disease, they have good prognosis. However, after some months or years, they develop the CNV, which is relatively common in these eyes. In the past, and I'm a surgeon with 21 years old doing vitreoretinal surgery, we were able to use the Matthew Thomas forceps in order to remove this subretinal CNV. And actually, we had good prognosis in these eyes because it was a type 2 membrane. But nowadays, makes no sense to do this surgery. And what you have to do when you have cases like that is that sometimes the visual acuity is very good, and the appearance is very bad, and the acuity is good. So it's important to treat the CNV as soon as possible with anti-VEGF therapy. And sometimes it's not necessary to follow all the clinical trials, the 3 doses, and after that, to perform monthly injections and something like that. Sometimes the response to anti-VEGF therapy is very good, even if we one single injection. These were the points that I would like to make. Congratulations for the case.
Yeah, I agree with that. I have quite a few patients who have this, and I have a couple of patients, actually almost the exact same story, did not show because of COVID and came back in and got worse. I have one patient with very good vision and her eye looks really bad, and she is not responding to anti-VEGF therapy. Most of the literature says kids or says young people do respond well, but I have some that are not responding well. But eventually, I think most of these patients lose vision, and so it's a little bit of a depressing diagnosis. Whether it happens in their young or when they're 40, 50, they eventually lose vision. So it's important to follow them up and treat them if they do develop this complication. Great case, though.
Thank you, doctor. And well, here I just brought a quick summary of the disease course, remembering that is an autosomal dominant gene that is causing this disease, known as PAST1, and it often appears on children from 3 to 15 years old, and the clinical stages they remark that there is a progression from the previtelliform until the 5th stage of atrophic alterations on the RPE and the macular area. So here, starting with stage 1 of presbytelliform with normal vision and subtle changes on the RPE and the altered electrooculogram. And here in the second stage, which is the vitelliform phase, known as egg-yolk lesions, with 30% of ectopic lesions. And sorry.
I'd like to, on behalf of the department,
okay.
Dr. Caroline for coming. We really appreciate it. And hopefully we can have some other lectures from you in the future.
Sorry, that was a great case. Sorry, I have to sign off at 11 because I have to leave where I am. They're kicking me out. But thank you so much for the great cases. That was it was wonderful. And I know you guys have amazing imaging where you are and all these interesting cases. So thank you for including me. It was so nice to see you.
Thanks, Carol.
Thank you. Take care, everyone. Stay safe. Bye.
Take care. Be safe.
Pode continuar, hein, Rô?
Ah, tá.
Desculpa.
Ok, não, desculpa. Achei que era... Tá bom.
Ô, Calango, continua aí. Ela teve que sair.
And then here in the third stage, we have this pseudohypopium in which there's a layering of lipofuscin. And this is similar vision on the second stage. And then we have the progression to the fourth stage, which is in which there is breakup of material, like this scrambled egg appearance on the OCT here, and with mildly decreased visual acuity. And then the last stage, which is the fifth stage, which is called atrophic, in which there is this important loss of visual acuity with central RPE and retinal atrophy. Well, this was a quick summary, and do you have any questions?
Por isso, Juan, que eu sou favorável, discussão de caso é para ter tempo de discutir. Essas revisões são legais para vocês estudarem, mas eu acho que na prática, eu falei isso para vocês no Grand Round, né? É apresentar o caso e dar tempo de discutir, e depois deixa essa revisão para vocês estudarem.
Maravilha, professora. Eu vou tirar esses
Doutora
dois
Nilva, o caso está bem redondo para o Grand Round?
O caso está bem legal para o Grand Round, Renato.
Mudaria alguma coisa? Então, corta a revisão final e a senhora me chama para
discutir. Sim, senhor. Corta a revisão final.
Então, quando acabar, eu entro para fazer alguns comentários, né?
Isso, porque aí, veja, a gente está tendo bastante ouvintes, né, no Grand Round, e tem no chat surgido bastante pergunta, que eu nem estou chamando, porque não estou tendo tempo, né? Então, eu estou preferindo dar uma enxugada nas imagens e mais direto para a gente ter tempo de discutir. Porque aí eu já chamo você, dá tempo de ter pergunta, e se o Michel, se o Maurício, se o Otaviano, se o Brant estiverem disponíveis, eles comentam também, entendeu? Hoje você vê, ela fez comentários bem legais, né? Foi bom ter apresentado.
Foi muito legal. A única coisa, viu, que eu faria, Renatão, é o seguinte, apresenta o índice Arden de 5-0 em verde para o Palmeiras, para a Nilva ficar feliz.
Mauricião, eu preciso checar com as pessoas que cederam o caso se essa criança fez EOG. Eu não tenho certeza. Não sei se a doutora Juliana está aí. Eu realmente não sei se a criança...
com você. É porque o time da Nilva, o nosso Palmeiras, ganhou 5-0 de um dos favoritos.
Não, a gente mostraria o EOG, mas eu acho que ele não fez, porque a imagem é tão típica que eu acho que dispensaram o estudo eletrofisiológico dele. Mas eu vou confirmar com os médicos do paciente se ele tem. Se ele tiver, a gente inclui, mas creio que não tem, não.
Então, eu acho que a gente pode só comentar e nem ir atrás do exame, não, Renato. É o que você falou.
É tão típico, né?
Isso, a clínica é soberana, entendeu? Você pode até comentar
Sim.
que poderia ser pedido, mas que a imagem não tem, ainda mais criança, né? A gente fica gastando dinheiro com exame.
Isso,
Renato.
imagina fazer o EOG num menino de 11 anos. É isso que eu vou comentar no final também, inclusive.
Ô, Renato, só uma questão em relação ao olho direito, que ele tem aquela lesão hiperrefletiva, não tem o sinal de decorrelação no anjo-ACT, né? Nessa imagem. Porque você pode ter fibrose sem ter uma membrana neovascular no BEST. E
Isso.
como a evolução dele foi positiva, então eu acho que nesse olho ele não tem uma membrana. Agora, no esquerdo, sim, isso é a membrana que aparece no BEST.
Perfeito, perfeito, Rodrigo. Concordo. A gente pesquisou e descobriu que eles chamam essa entidade de pilar fibrótico e que não necessariamente o pilar fibrótico tem origem neovascular. Então, você vê que não respondeu ao anti-VEGF. Então, só fizeram uma e, como não respondeu, concluíram que essa lesão realmente não é responsiva a anti-VEGF, que não e seria diferente de uma membrana típica, né? Ele é apelidada de pilar fibrótico no BEST. Eu não conhecia isso. Foi até interessante aprender isso com esse caso.
E a outra coisa que aquele líquido é história natural. Vai e volta sem a membrana. E você pode achar que é uma membrana. Né?
Perfeito. Foi o que a gente concluiu também. Então, evitar chamar de membrana e talvez introduzir o nome pilar fibrótico. A gente ficou em dúvida se introduzia esse termo no caso, por ser muito específico, ou se chamava de membrana mesmo.
Ótimo.
Eu acho que tem que introduzir isso porque não é membrana, né?
É verdade. Ótimo, então, Juan. Vamos falar, então, explicar o conceito do pilar, que não é neovascular, e por isso que não respondeu. Acho que isso é bonito do caso também. Imagina ficar injetando uma criança de 11 anos, sabendo que não vai responder, entendeu?
O importante, viu, eu acho, Renato, agora sem brincadeira, que é um caso que tinha uma fibrose, né, perilesional, que acontece nesses casos e que se confunde com a membrana vascular subretiniana. Então, a mensagem que tem que dar é que nós não temos nada para fazer para BEST, a não ser tratar a membrana vascular subretiniana secundária em alguns casos de BEST, entendeu? Então, para você ter a certeza, é importante você ou ter exames diagnósticos que comprovem que a membrana não é fibrose, né? Ou você fazer o teste terapêutico, que se você não tiver uma resposta legal, você simplesmente deixa de fazer o tratamento, tá legal?
Perfeito, é isso que a gente vai enfatizar, sim.
Legal, bacana.